thanks to all the learners for joining us today. As I mentioned last week, our talk was focused obviously on the 101 or basics of serologies. We're actually going to kind of reinforce most of that information that was presented last week here and actually spend another session discussing serologies. And the reason for this is that I think this is somewhat of a barrier to provider understanding and adoption of kind of wider management around Hep B in their practices. The serologies, the terminology we give, various patterns of serology can be confusing, and really want to spend an extra session today going through this and answering any questions so that we could really kind of address the needs from particularly a provider standpoint. So talking about serology, part 2. So we'll go back to our case study that we've been building on since module 1, but this is a 28-year-old woman born in the United States. Her parents immigrated from Taiwan 2 years before she was born here. As you will recall, we talked in the first session about how to engage people who are at risk for hepatitis B infection around having that discussion about the importance of screening and what we can do with screening results to better engage patients. And this patient accepted to be screened or tested for hepatitis B. So the screening tests that were ordered were their hepatitis B surface antigen, the hepatitis B surface antibody, and the hepatitis B core antibody. And the results showed that her surface antigen and core antibody were both positive, while her hepatitis B surface antibody was negative. So the question that we were left with is, now what do we do with these test results? So, and I think what we'll do, Rachel, is we'll come back to a discussion of this towards the end and open it up. So just to go over kind of our Serology 101, our first step when we're talking about testing or screening somebody for the for hepatitis B infection is to obtain these 3 tests. So the hepatitis B surface antigen, which again is really the marker of active infection, and part of the definition for chronic infection has to do with how long the surface antigen has been present for at least 6 months. So if anybody has this marker and it can come back as reactive or positive, that means they have infection with hepatitis B. Now, the other 2 screening tests that we obtain include the hepatitis B surface antibody, and this is typically a marker for immunity to hepatitis B, and also the hepatitis B core antibody. This is typically a total IgG antibody, and it is simply a marker for prior exposure. We talked a little bit last week about how really, 3 out of 4 or 9 times out of 10, this will go with prior exposure. Less commonly, there are other interpretations of somebody who's just isolated core antibody, including being a false positive test. Anytime we're suspicious of acute hepatitis B infection, and the test question that often you will see on your board examinations for internal medicine or family medicine will be whether or not the IgM core antibody is positive. And that's something that you will typically see during one of those window periods and should really make you think of acute infection if that's positive. But typically the test that's ordered is the total IgG, the core antibody, not the IgM. And if that surface antigen test comes back positive, this should really trigger us to have a discussion with the patient to let them know that they are infected with hepatitis B and that we need to do some additional tests. So kind of the step 2 in the screening process, once somebody tests positive for surface antigen and you've informed them of their test results, is to bring them back in and have some additional testing. And the additional testing includes, but is not limited to, so these are the serology tests you want to be sure to test for, and that is the hepatitis B E antigen test. This can be a surrogate marker of higher viral load or kind of these earlier phases of infection, which I'll talk about on the next slide. And then over time, typically people will lose E antigen and develop E antibody. So you also want to check E antibody. And this can sometimes be associated with a lower viral load and or pre-core or basal core promoter mutations. And then finally, the third kind of serology test we talk about in somebody who's surface antigen positive is the Hep B DNA PCR viral load. So this again is to measure how much active viral replication is ongoing in a person. And these three tests, along with an ALT and an assessment for fibrosis, which we can discuss a little bit towards the end, really are what informs recommendations around treating with antiviral therapy now versus kind of watchful waiting. And we'll be talking in the next session, module 4, about how you take all of these test results and you translate it into a management or action plan, if you will, for your patient. So again, step 1, screening test. If your surface antigen is positive, you want to be sure you check these additional serologies as kind of your step 2, the E antigen, the E antibody, and your Hep B DNA PCR viral load. I think one part that we talked about a bit last week that really is a sticking point, it actually, unfortunately, I think for a lot of providers has turned into really a barrier, is some of this confusing terminology that has evolved a bit to, I think, a little bit better place more recently. But the nomenclature we use to describe these various kind of quote unquote phases of hepatitis B that typically happen over time can be confusing and don't always reflect very well what we think or know is going on with a person and their liver disease. So what we've included here are some of the old terminology and some of the updated or newer terminology. And I do think the newer terminology, this is my personal bias, is better because it's more descriptive. You know, some of this old terminology includes terms like inactive carrier, and I think that has over time, for some providers, led to a lot of confusion about how can you be a carrier and it's inactive, and what does that mean about your infectious status and your risk to progressive liver disease. So I think these newer updated terminology are really a concerted effort by the folks in kind of the liver realm and public health space to talk about how we can make terminology more reflective of what we think is going on for a given patient. So as I mentioned, tests that you want to obtain in anybody who tests surface antigen positive includes the hepatitis B antigen test, which again, in an earlier phase of infection, typically in the first, up to a couple of decades, this E antigen will be positive. And then over time, you go from usually losing, being E antigen positive to losing E antigen and developing E antibody. And that's why this is another test you check in somebody who's surface antigen positive. The third test I mentioned on the slide before was the Hep B DNA. So kind of wanted to put this all together and put it in the context of these quote unquote phases that we talk about with liver disease. So in these earlier stages, as I mentioned, your E antigen will be positive, and typically your Hep B DNA is quite high. It might be actually the highest it'll be in those earlier kind of time points. So anybody who is E antigen positive with a very high viral load, usually I'm thinking they're kind of in an earlier onset or stage of infection. And in this case, typically the ALT is what we call normal, but can cycle in these earlier kind of phases to be elevated as well. But the classic kind of phase description, and unfortunately not all our patients sometimes meet these, these descriptions. But the ALT typically will be normal. And this is characterized from a liver standpoint as having not so much significant fibrosis or liver disease at that point. But what happens over time is that, again, you lose this E antigen and develop E antibody over time. And that typically correlates with your Hep B DNA viral load coming down over time. And then this also is paralleled typically with a slow but typically a rise in your serum ALT test, which is one of your liver enzyme tests that you can check as part of your hepatic panel. Your comprehensive metabolic panel will also give it. But again, you'll see kind of the dashed line gives you some areas or gray areas for some amount of fluctuation during these phases. This phase is typically called immune clearance. So your body's clearing the E antigen and developing E antibody. And that's where the clearance term really comes from, and the DNA level coming down. We now kind of refer to this just as a chronic hepatitis phase. And then this is followed by what we used to really give the terminology of inactive carrier. But we're moving towards, if you will, the description of normal or, inactive hepatitis. Again, where your E antibody positive, your viral load you're measured by the Hep B DNA PCR is low, and your ALT is typically low. So this is very different than kind of these earlier stages where your Hep B DNA is typically very elevated. And then over time, having this virus, there's injury followed by regeneration and healing, with kind of a progression for some patients of developing fibrosis or scarring reaction in the liver. And this is the phase we typically refer to now as kind of progressive fibrosis. And these are the people who are certainly at highest risk for developing cirrhosis and or liver cancer. But remember, hepatitis B is one of the rare liver conditions in which you can actually develop liver cancer independent of having cirrhosis, which is typically not the case for other etiologies of liver disease. So if we take kind of some of that old terminology and this new terminology, I think looking at it this way is sometimes somewhat helpful in terms of assigning some levels of threshold, particularly when you're talking about the DNA level. So anytime your surface antigen is positive for at least 6 months, you're defined as chronic Hep B infection. If that surface antigen at any point, and this can happen, and we'll talk a little bit about it next week. Some people have spontaneous loss of their surface antigen over time. This happens pretty rarely, probably in less than 1 to 3% of people, and sometimes treatment can increase your chances of this. And so if you go from being surface antigen positive to negative at any point, you're considered resolved of your Hep B infection. But most people we're talking about are in this chronic Hep B infection. So they have surface antigen that's positive. And when we're talking about high, intermediate, and low, this is in reference to titers. And titers, to be honest, are not something that we typically check routinely when we're talking about surface antigen. So just know that if that's positive or reactive, again, it usually goes with the chronic Hep B diagnosis. Now, this is kind of then further split into whether or not you're E antigen positive or you're E antigen negative. And if you're E antigen negative, you're going to be typically E antibody positive. Okay, so that's why you see E antigen positive here, and then you transition to losing that E antigen, that immune clearance we talked about, and then developing E antibody. The Hep B DNA, again, in that early stage when your E antigen is positive and your viral load is very high. And when I say very high, we're typically referring to a DNA PCR level in the order of 10 to the 7th IUs per ml. One question that has come up in a prior boot camp is sometimes some labs use IUs versus copies per ml. So that's another way to report the results for this test. And the conversion factor is typically 1 IU is equivalent to 5.3 copies per ml. So for somebody who has a viral load of 2,000 IUs per ml, that typically translates to about 10,000 copies per ml. So a very high viral load, we typically think of on the order of 10 to the 7th IUs per ml. And then over time, again, in that early phase, you usually have a normal ALT. The old terminology was immune tolerant. The degree of liver disease is very minimal to none with respect to fibrosis typically. Over time, you'll still have that E antigen. You might be transitioning to losing that E antigen, but your viral level will typically come down to a lower range. So if you're following this person over time and you see a very high viral load, in somebody who's e antigen positive and ALT normal come down a bit, you want to take a careful look at that ALT and see if that looks like it's going up, because this could be, again, in that phase of having more significant liver disease here, moderate to severe, when we're talking about inflammation and also developing now some degree of fibrosis over time. But usually this is in reference to more inflammatory scores on the liver biopsy. And then you go from an e antigen positive phase, as I mentioned, to an e antigen negative phase where you develop e antibody. And in this phase, you typically might start out kind of in a lower viral load category, less than 2,000 IUs per ml. Your ALT might be normal, and you won't, again, still have much in the way of fibrosis and maybe not even severe inflammation. This is the phase we used to call inactive carrier. And then this is followed over time. And usually I'm talking about, for most people, decades of time, unless they have something else contributing to a more rapid onset of disease progression. And examples of that might include concomitant alcohol use, another form of liver disease. We have some people who have Hep B and Hep C. We have some people who are co-infected with HIV, which we know lowers our threshold for faster fibrosis as well. And so this is followed then by somebody who might have a rise in their Hep B DNA. The ALT might be elevated. And again, in an e antigen negative patient, this should make you think of more progressive fibrosis, again, in that moderate to severe stage. The only way to really assess the degree of liver disease are doing some type of assessment for inflammation and or fibrosis, which is kind of a standard part now of our workup. There are a lot of non-invasive ways to do this. There are a lot of scores we can use, things called like the FIB-4 score and the OPRI score, which just use age and laboratory values that you would typically check in these patients to calculate whether or not somebody falls into a low fibrosis or a high fibrosis stage. We used to, before we had some of these non-invasive markers worked out, we used to think about when to biopsy a patient, and usually sometime in here would be the phase in which we would biopsy a patient. We do very few biopsies in this patient population for most providers, depending on the setting in which you're working, but it still is a way for us to assess how much inflammation and scarring. As you will talk about kind of in next week's talk, the whole goal is to try to identify patients who are transitioning kind of in between here to here, to know whether or not to initiate antiviral treatment. So we'll talk a lot about these thresholds in terms of viral load, your e antigen status, and your ALT. And then in terms of other ways to non-invasively assess for liver disease or damage, most notably scarring, there are some non-invasive imaging modalities and technologies that have been developed now, such as FibroScan, MR elastography. All of these things kind of use imaging modalities, and sometimes that includes sound modalities with them to measure how elastic the liver is, and that translates now into a fibrosis score. And in anybody who's developing progressive fibrosis, they are recommended to be considered for antiviral therapy. And we'll talk next week also about how once you initiate antiviral therapy, at the current time, our therapies are typically lifelong, unless you lose surface antigen, and it shows resolved Hep B infection for the most part. All right, so that kind of, again, goes through in a little bit more detail, hopefully, kind of some of the old terminology, the new terminologies, how this breaks down into what we call the different phases or liver diseases we see. I will say that patients don't always fall into one of these categories. And so this is just really meant to the best extent possible for the tests we have available for Hep B, serve as somewhat of a guide to try to then take this information, and we'll talk about next week how we translate it into a management or an action plan. But I think this ends up being somewhat of a sticking point, a barrier, if you will, to adoption around Hep B care. So turning over from spending some time on those kind of different stages and phases, if you will, of liver disease, wanted to kind of put this into context of some patient kind of case scenarios. So none of these are real patients. There are no identifiers here, but want to kind of get us in the habit of thinking about how we translate some of those test results into a description of some sort to assess liver disease in that patient. So we'll start here at the top. So we have a 52-year-old Korean male who is surface antigen positive. So again, if you're surface antigen positive, you have chronic hepatitis B typically. This person is e antigen positive. You know, they're 52 years of age, higher rates of certainly mother to child transmission in Korea, or early childhood transmission based on some of the epidemiological things we discussed in the first talk. So they've lost e antigen and they are e antibody positive. This person's Hep B DNA is negative or not detected, and their ALT is normal. So if you go back to a couple of slides to kind of those different phases, this person would kind of fall into that normal or inactive hepatitis kind of phase. Again, the Hep B DNA being negative, right, and the ALT being normal in this person who's e antigen negative is kind of the test results that drop us into that, phase of liver disease. Now, I will also give the caveat that while this kind of helps us tell us what phase a person might be in, you still need to do the fibrosis assessment and all the other information to know whether or not it's appropriate to recommend antiviral therapy. And again, we're going to talk about this in more detail next week. The second case is somebody who's a Vietnamese male. This person's younger, 38. They're surface antigen positive, so they have Hep B. They're e antigen positive, okay, and their Hep B DNA is elevated, as is their ALT. So this is somebody who would fall into that chronic hepatitis kind of descriptor. The next case is a Nigerian female who's also young at 25, who's surface antigen positive, so you know they have chronic Hep B. Their e antigen is positive, and here their Hep B DNA is very elevated and their ALT is normal. So that should make us think of, again, what we used to call immune tolerant, but we now call normal or minimal hepatitis. So again, those earlier stages of infection, typically, and in people who acquire this at a young age, it's not uncommon in their 20s and 30s to be in this, what we used to call immune tolerant, but now normal or minimal hepatitis phase. And then finally, the last kind of case scenario here to help put this into context is a 52-year-old Taiwanese female. She's surface antigen negative. Her surface antibody is negative and her core antibody is positive. So she's somebody who's isolated core antibody positive. So we talked about this in the serology talk last week, whose ALT is normal. So this person is typically most commonly, again, 3 out of 4, 9 out of 10 times, resolved infection with waning surface antibody titer. We talked about, there is a chance that it could be a false positive. It could be, another less common interpretation. I think last week, I think it was Lydia from this learner group who talked about, are there some additional tests that would help us? So we said repeating some of these tests in a time frame, usually of about 6 months or so. And then also in this scenario, doing some additional testing, such as the e antigen, the e antibody, and the Hep B DNA test to make sure, one, you're not dealing with somebody with what we call a cult infection. 2, we think that core antibody is real. And if your e antigen or e antibody is positive, that would suggest that this is a real core antibody. Really associated with resolved infection if that DNA comes back not detected. Okay, so again, just to give us kind of different scenarios and how we think of them with respect to how we are now describing patients with Hep B. So I'm going to open it up to questions here, and then I would like to go back to our 28-year-old case, and then also go back to the case that Vikram, you submitted last week. That was really helpful, and we can talk about how that patient maybe fits into one of these categories. So I'll stop here and let's open it up to questions, and then we'll go back to the 28-year-old case I presented at the beginning, and then Vikram's case. And you can feel free to use the chat function if you prefer, or feel free to chime in taking yourself off mute and asking a question.
Hi there, this is Chelsea from Hepatitis Education Project.
Hi, Chelsea. How are you?
Good, how are you?
Good.
We have previously met with, I think, a PA who mentioned that if somebody is core positive,
Okay.
most likely has waning surface antibody, that they actually re-immunize to see if that surface antibody will become detectable. What are your thoughts on that?
Yeah, so I think this is an area of somewhat of some debate, and I'm happy to share with you, Rachel. We have that CDC frequently asked question that I think one of the learners from the earlier sessions kind of shared with us. So yeah, as you said, most of the time that's going to be somebody who has been infected previously, and either never developed the titers, or the titers for the surface antibody waned over time. So the question you're asking is, like, really, what is the benefit of doing a vaccine series to try to boost that surface antibody? Is that correct?
Yep, that's correct.
Okay, so I think that, and anybody who's clearly been infected before, we typically don't recommend vaccine series, because again, that core antibody, the way you distinguish, we talked about this last week, and I'm not sure if you had the chance to join us last week, but all of these sessions are actually still available online, so keep that in mind. We talked about how the core antibody is helpful in somebody who may or may not be positive for surface antibody test. So the surface antibody test tells us somebody who's immune from vaccination. And if that is absent and or the core antibody is present, so the core antibody being present really means that they've seen the virus before. They've been infected before for, again, the 3 out of 4, 9 out of 10 cases that you're going to see. And so in that scenario, there isn't really any strong guidances or recommendations that vaccinating that person helps them, helps achieve, anything really a benefit from a public health standpoint. So that's not somebody who technically can, really get reinfected. It's not somebody who is clearly going to benefit from a vaccine, from getting a boost. Now, all of that being said, this PA that you spoke to might have a practice of doing this and seeing that the surface antibody titers go up a bit. But there is nothing in the guidances from the CDC and others that really say that that is something we should do for somebody who's been previously infected. We did talk about kind of in the first module that there have been these studies done in California and other places where some people are not checked or screened who fall into a risk category who then are immunized. Did the PA, I'd be curious to know, what treatment setting does that PA work in? Is it to try to show antibody titers for employment?
So this was a PA actually with a pharmaceutical company who does community education. So I'm not sure what area she practiced in, but she was mentioning that she does vaccinate to try to make that immune response.
Yeah, there's nothing
would show definitively antibody positive.
Yeah, there's nothing in the recommendations that say that's something that we should be doing that is clearly helpful. So we typically don't encourage that practice. Yeah.
Great, that's helpful. Thank you.
Yeah, you're welcome. And I do think, Rachel, that CDC FAQ could be helpful. I'll take another look at it and see if there was something in there from it.
We'll share that with everyone.
Yeah. Any other questions? General questions? Again, I think we really wanted to take some time today to see if we could work through.
Ponni, it looked like Joanne had a question.
Yes. Okay, thanks for alerting me to the chat.
Yeah.
Can you discuss infectivity with core antibody only positive? Also, can you discuss vaccination of history of all 3 vaccines, but surface body antibody negative, booster, or all 3 vaccines again? So that's a really good question. Let me start kind of piece by piece here. So discuss infectivity with core antibody only positive. So you typically need surface antigen to have, be infectious with hepatitis B. I will tell you there's a couple of caveats to that though. So there is a class of patients who are defined as having occult infection, where the only test that's positive is actually their core antibody. This is typically very rare. It tends to happen in geographic areas with high rates of maternal to child transmission. We actually, in our community-based outreach program where we do a lot of testing, particularly in the West African community, actually brought a lot of people who are core antibody positive back to try to get at the question of how many people would actually have detectable DNA. The DNA is, 19 out of 20 times not detected, 1 out of 20 times might have a very low level of viremia. Occult infection by definition means that you don't have that traditional surface antigen test that comes back positive, but there is hepatitis B living somewhere in the body. And this is kind of a frustrating issue because it is pretty uncommon and rare. And it sometimes can be detected when we do check the Hep B DNA, but sometimes even when you check the DNA and that's negative, they've found it when they've done random liver biopsies on patients. And they actually can stain for hepatitis B virus and they see it in the liver. So this kind of leaves us a bit unsatisfied, but the only things I can reassure you is that this is a pretty, uncommon phenomena. It happens, very rarely. We don't have good tests at the present time. We don't recommend biopsies on people who are core antibody positive because for most people, that core antibody isolation, the only test being positive on the screening test is not associated with having any active infection. But there is this really uncommon thing, and you'll see it if you Google it, you look in PubMed, look for occult Hep B infection, and it's very difficult for us to find, and we don't have good diagnostic tests for it. So somebody who's core antibody isolated positive is not typically considered infectious outside of if they had like a low level of DNA that was positive in this occult infection scenario. So we typically counsel patients that you're immune, you likely have seen prior infection before, but don't have any signs of active infection now. In my opinion, I again check the other tests as a specialist, the e antigen, the e antibody, and the DNA to really feel like I've confidently or as confidently as I can ruled it out. We don't say that you can transmit that virus if you're only core antibody positive. Now, in the 5th talk, so we're in talk 3 today, so in 2 weeks, we're going to talk about this concept of reactivation. So reactivation is something that can happen in anybody who has a core antibody that's positive, independent of whether or not they have the surface antibody positive. So anybody who is core antibody positive actually means that they've been infected at some point, and they may be still harboring some integrated virus in their host genome through this covalently closed process that Hep B DNA can do. Now, it doesn't mean that they have active infection, but what it means is that in the setting of immune modulation or immunosuppression, what was a not infectious state can flip into being an infectious state where your surface antigen becomes positive and your Hep B does something called reactivation. So outside of that, again, and you're just core antibody positive, you are not felt to be infectious. I do check that DNA test with the other tests to really make sure I've ruled out occult infection because of the rare cases where I have seen it. And then the second part of the question from Joanne was, can you discuss vaccination if history of all 3 vaccinations, but surface antigen negative? And I'm going to get to some of the other questions that are coming through the chat kind of one by one. This is great. So can you discuss vaccination of history of all 3 vaccination, but their surface antibodies negative? Do you do a booster or all 3 vaccinations again? So again, I think this is where there is some guidance in that CDC document, Rachel, that we can share with the learners. Typically, I will vaccinate all 3 again, but I try to get a sense of what schedule the vaccination was done on and whether or not there were other things going on with the patient. So I'll tell you some examples in which you're more likely to see surface antibody titer or test negative in somebody who reports they're vaccinated. So number 1, you always want to make sure that the person, if they were at risk for Hep B, was screened appropriately the first time. So I just mentioned these studies that have been done, particularly in California, in Asian communities, where they surveyed everybody about whether or not they had been vaccinated before for hepatitis B, received all 3 doses, and then all of the participants underwent Hep B screening. And they found that up to 15% of people were inappropriately vaccinated with all 3 doses of the vaccine, but actually were surface antigen positive or infected with Hep B. And that's not a scenario, again, for patients who are infected with Hep B. They won't have any really positive response of losing Hep B infection with giving them a vaccine. So we don't believe, vaccines have any role in somebody who's infected. So the first thing in this kind of scenario would be to make sure that that person has been appropriately screened if they were at risk, ever in their lifetime for Hep B. So taking that off the table. The other things I find out from the patient who's really been vaccinated, and sometimes the vaccine schedules aren't done according to the schedule, or they are and you still don't develop it. But I kind of find out what other things are going on with the patient that might make them more likely to not have a surface antibody titer that's positive, particularly in a young person. Definitely as we age, the titers can wane over time, but the CDC and others have done studies to show that even when your antibody titer drops below the threshold of detection, in somebody who is not infected and was vaccinated, they typically actually still do have immunity, even though the surface antibody has waned over time. So I typically will redo the series, and I might do it on a different schedule than what they got before. So if they got the standard 0-1 6-month schedule, I might try to do it on an accelerated schedule. We see higher rates of that surface antibody being negative in somebody who's been vaccinated if they're kind of at the extremes of age, so older in age, and or if they have comorbidities that might make it harder for them to mount an immune response. So somebody who has HIV, somebody who has advanced other liver disease. So like, for example, if I have a cirrhotic patient with Hep C and I check their Hep B status, I might give them the standard 3-dose vaccine, and I always check all of those patients to see if they develop a protective antibody, but they have a higher rate of not developing a good immune response to develop good antibody titers. So I hope that kind of answers that question. And there is some guidance. I have to look at the CDC doc, Rachel, again, about the role of boosters. And I think that's usually in younger people with no comorbidities. There is an option for a booster, but let me get back to Joanne with that part of that question. But typically I would repeat the standard 3 vaccination schedule. So Jia Jiang from Hepatitis Education Project, should we be recommending total core antibody testing for those who are undergoing screening and treatment for Hep C? Yes, due to reactivation, and absolutely yes. So typically, our screening guidelines include to check all 3, but especially whenever you're thinking about a risk of reactivation, and I cover this in the 5th talk in 2 weeks, all scenarios of reactivation. So reactivation is, again, where you've been exposed to hepatitis B. Your core antibody typically will be positive. You may not have a surface antibody that comes back positive. And all of those people are recommended to be monitored and are prophylaxed for Hep B, depending on if you're being treated for Hep C. There are different scenarios or what degree of immunosuppression, and we're going to go through these categories in 2 weeks. So yes, always check your core antibody status, Jia Jiang. I think that's a really great education point, particularly anybody undergoing treatment for Hep C. We've actually had deaths due to reactivation in the context of treating patients for Hep C because their Hep B reactivated and people weren't screened appropriately or prophylaxed. The reactivation risk is higher in somebody who is both surface antigen and core antibody positive versus somebody who's isolated core antibody, but it can still happen in somebody who's isolated core antibody positive. Okay, and CDC guidelines appear to only recommend surface antigen and surface antibody screening. There's actually been position papers, Jia Jiang, I can share with you from ASLD and other professional societies stating, and I think the CDC also actually issued an MMWR report in the last 1.5 to 2 years about this risk of reactivation in the setting of Hep B treatment and recommending screening for all those patients. So we can get you that resource or information. And then finally, do you recommend HBsAg at birth? So I love this because you guys are all thinking about what's ahead in the next 2 talks to come. So actually in the 5th talk in 2 weeks, we're going to talk about how we can decrease our risk of mother-to-child transmission and the role of HBsAg, which is hepatitis B immunoglobulin, and why we recommend to give it at birth in babies born to mothers who have Hep B infection. So do you recommend HBsAg at birth if core antibody positive only? So no, it is not recommended for somebody who is core antibody positive only. Again, mother-to-child transmission is in mothers who are surface antigen positive and highest in, not just surface antigen positive, but then in those who have surface antigen positive, those who are e antigen positive, and those who have Hep B viral loads that are very elevated. And so those 2 things are kind of the branch points for recommending what we call immunoprophylaxis for infants at birth, which is typically within the first 12 hours. And that's typically done with a combination of hepatitis B immunoglobulin as well as hepatitis B vaccination. So that's going to be covered in 2 weeks as well. We have kind of a special scenarios, different populations talk that we've put all of this into reactivation and mother-to-child transmission. So that will be in 2 weeks, Joanne. So I think you might find that of particular interest. Okay. This is great. These are great questions, great discussion. So are there any other comments or questions folks had? And if not, we can go back to the first case and then we'll go back to Vikram's case from last week. Okay, so what I'm going to do is so let's go back in time here. So let's go back to the 28-year-old woman. You've screened her. She's both surface antigen positive and core antibody positive. So what do we want to do for her next? And again, use your chat feature and or take yourself off mute and feel free to chime in. What would be the next step for this person, this patient? So what is the interpretation of these test results? So somebody with so the surface antigen's positive, so they're infected with hepatitis B. So we talked about kind of what's the next step once you find out somebody's surface antigen positive. What other, so let's start with what other serology tests you want to check. Okay, Joanne, thanks for answering in the chat. So you want to test the DNA viral load, the Hep B e antigen ALT. Perfect. You got it. That's right. So those, the DNA, the e antigen are kind of the serology test, and then there's the kind of the other liver workup, which would include an ALT test. And so these tests are helpful because they can then help us try to get a sense of where they might be with infection. And then these test results are used to really come up with our management plan, which will be the focus of next week's talk. Okay, I think in the interest of time, what I'm going to do is I'm going to now pull up, and Vikram, are you with us today? So let's pull this up. So this, does everybody see this? Can you see this on my screen? Rachel, we good?
Yes. Yep.
Great, thanks, Chris.
You can
Thanks,
see.
Rachel. All right, so let's go back to the case he had submitted last week. So this again was a 55-year-old Italian male. And this was somebody who had family history, of, I believe it was cirrhosis, not liver cancer. And so immediately I'm always thinking, you know, was this somebody who had early childhood transmission and or mother-to-child transmission? Being born in Italy doesn't put you in the highest risk category, but probably in that intermediate category based on what we covered in the first talk with epidemiology. So here are the test results. So surface antigen positive. So this should then lead us to, so they did surface antigen positive, their core antibody was positive. And so this should lead us to do some additional testing, which included the e antigen, which was negative. And so I think e antibody was also checked and that was positive. So this is somebody who's lost e antigen and is e antibody positive. And The Hep B DNA came back as 10,000. I'm just going to interpret this as IUs per ml because that's the default we used on this form. And their ALT test, so look down here. So look at this. So the ALT test was 82. What's a normal ALT test? Any thoughts on what might be a value for a normal ALT test? And we're going to talk about this in more detail next week. So a normal ALT test, okay, 82 is elevated. Yes, Joanne, that is absolutely correct. So ALT is elevated. Most of the assays we use might have a upper limit of normal for the ALT test. And remember, this might differ depending on the different lab that's running it and the reference range. So you need to really look at the reference range. But most reference ranges, the upper limit of normal, like the upper limit of normal in our system is 45. It used to actually be 54. And I think it's as low as, you know, upper 30s to actually into the 60s and higher. But what we know is actually based on, they took a whole, we've done studies now where we take all these healthy volunteers and we measure their ALT, and then we broke it out by gender. And there's actually a gender difference with your ALT. But really what's a normal ALT is probably something less than 35 based on those healthy volunteer studies where they ruled out any liver disease. And so actually the thresholds we use for men and women are actually less than 30. So, you know, true normal for a woman probably is around 18 to 20, and for a man is around 25. So ALT, yes, 82 is even by your reference range probably going to be elevated. So this person has an elevated ALT, a DNA level of 10,000. So it's not quite 10 to the 7th. This is like really 10 to the 4th, right? And their surface antigen is positive, their E antigen is negative. So they're kind of not in the first two buckets of the phases we talked about on the slides, but kind of in the second two buckets. And then, you know, their DNA is greater than 2,000. So if you go back to that slide, it's a little hard for me to toggle back and forth here. And their ALT is ranged. You know, that this is somebody kind of probably has had the virus for some amount of time, which kind of would have been my guess if they have a family history of liver cirrhosis, if this is related to Hep B. They're from Italy, so they may have acquired this either, you know, we don't know at what point in their life, but probably earlier in their life to have this pattern. And so let me see if I can actually, at this point, hopefully I'm not confusing anybody here, but let me see if I can go back. So I'm going to stop share, and let's go back to my PowerPoint slides if I can find them. Here we go. We go here. So again, their ALT is elevated. They're more than 2,000 IUs. They're E antigen negative. So again, this might be somebody who you're thinking, particularly in your 50s, because you develop more and more fibrosis as we age, that is more likely to be kind of falling into this more moderate to severe liver category with the chronic hepatitis. So this is somebody who automatically I'm thinking might need a very detailed assessment, not just for fibrosis, but consideration potentially for antiviral therapy, which again, that's gonna be the focus of next week's talk.